Hello, everyone. So, this live was actually scheduled at 7:30 p.m. today, but I am starting it early since I'm busy at 7:30 p.m. today. So, this is an early live, and this is really unplanned live. So, I'm so glad to return back to the Is Pharmacology Difficult weekend classroom. This concept was introduced long back, and now I have again reintroduced it. So I'm so glad to be back again in Is Pharmacology Difficult Weekend Classroom. And as you know, the basic concept is always the podcast summary of the week. So I will be covering the topic of beta blockers. So let me add my slides to the live stream. And actually I was not planning to do initially I was not planning to do a live stream, but now I have thought of making this a live because I'm not very good at live streams, so this is a kind of an experiment on live. So without any delay, let's begin it. So it's Pharmacology Difficult Weekend Classroom, and I've written the date, and the topic of the day is beta blockers. So first of all, we should know it's basically this weekend classroom is a weekly podcast summary, and the purpose is actually to revise, definitely revise the what we have done or what you have heard in the audio podcast, and then learn. And after learn, evaluate yourself. Evaluation will be done at your own end, but revision and learning can be done here, since I will be covering again the same important details, nothing more extra. Rather, it will be more of a summary. And for detailed, all the details, you have to actually go to the podcast website, that is www.ispharmacologydifficult.com. So now let's begin. I'll be beginning from the beta blockers introduction. That is, I think I'm also covering the episode 150th. Though this week the episode was 151st, I'm covering 150th episode also. So first of all, I would like to say that beta blockers are basically very useful drugs. They are very useful, especially for the treatment of hypertension, ischemic heart disease, that is IHD, then congestive heart failure, and cardiac arrhythmias. Now, the most special characteristics of the beta blockers that we actually make use of is there specificity for the receptors like beta 1, beta 2, beta 3 receptors. And they have some of the drugs, they have intrinsic sympathomimetic activity. Then some of the drugs, they have capacity of vasodilatation. Then they have very specific pharmacokinetic, pharmacodynamic profile. And they have a varied lipid solubility, membrane stabilizing property. Some of the drugs also possess additional alpha blockade capacity. Now, for your just a revision part, we'll go to the next slide. And now let's come over to the drugs. The most selective and the most non-selective, sorry, and the prototype drug is a propranolol, and it has great affinity for beta 1, beta 2, but it has a little lower affinity for beta 3 receptors. The other highly selective drug for the beta 1 receptors, they are metoprolol, atenolol, acebutolol. Then we have bisoprolol, esmolol, etc. They at high concentration they block the beta 2 receptors also. Then catecholamines, they are absent. Then many beta blockers, they show intrinsic sympathomimetic activity. And these specific drugs, they are pindolol, acebutolol. They can partially activate the beta receptors. They will not significantly do that. It will not be a complete agonistic action. It will be a partial agonistic action, and that is known as intrinsic sympathomimetic activity. That is when the catecholamines, they are absent. Now, but you should know that propranolol does not possess this intrinsic sympathomimetic activity. Now, Other drugs that block the alpha receptors, they are levodopa, carvedilol, and bucindolol. There is a good amount of vasodilatation that is found in drugs, beta blockers like celiprolol, nebivolol, nipradilol, cartiolol, bopindolol, then bitexolol also is there, and biventolol is also there. They all show at these vasodilator properties. Then there is additional membrane stabilizing or local anesthetic property, which is a feature of the beta blockers like acebutolol. Then we have propranolol, then carvedilol, etc. Next, you should know that beta blockers, they are not affecting the resting heart. They have a profound and pronounced effect on the active heart, that is in the state of exercise, stress, when their sympathetic discharge is much more than normal. Then only beta blockers show their pronounced effect. Now, another classification for beta blockers is on the basis of generations, that is first generation, second generation, third generation. So non-selective beta blockers, they all belong to the first generation. Beta 1 selective blockers, they belong to the second generation. And when the beta blockers, they show prominent cardiovascular effects, they belong to the third generation. And when I'm talking of cardiovascular effects, then I'm especially talking about the vasodilatation property. That is the property. And now the next slide is actually, yes. Now we are coming to the serious effects of the beta blockers. Now we're starting with this week's episode, that is 151st. Now, beta blockers actually affect the heart, again to repeat, in the active state, not in the resting state. That you have to make it very clear, when the sympathetic tone is prominent, like in the state of stress, anxiety, exercise, etc. There, they antagonize the inotropic and the chronotropic effect of the catecholamines. There is decreased or slow heart rate and decreased contractility of the heart. This cardiac depression is basically explained. Mechanism is quite insignificant and vague. Cardiac output is also decreased. If they are used for less duration, now we need to know the effect on the peripheral resistance. That depends on their use. That is whether they're used for short term, whether they're used for long term. So that you need to actually understand properly. When they're used for short term duration, then the peripheral resistance actually increases. And when they're used for longer duration of time, then the peripheral resistance actually becomes normal or it is decreased. And then there is a special case when alpha plus beta blockers combinedly they are administered. Then cardiac output is normal, but the peripheral resistance is decreased. Other effects I can say upon sinus rate, that is decreased. Then conduction is decreased, especially in the atria and the AV node. Other effects, they are in the state of exercise. That is, you need to understand this also. In the state of exercise, when the heart is very active, there is a greater depression of the heart rate and the heart contractility. But in this particular exercise state, the cardiac output, it is not much affected. Now, what are the concomitant effects of aging? Aging also modifies the results. The heart rate increases in the normal, healthy people, and it is not very prominent. It is quite insignificant, while heart rate is much more in the younger age group. Cardiac output preserves. In the old people, they are marked. Why? Because the stroke volume is also increased during exercise. The work capacity, it is depressed. And the non-selective agents, they also depress the exercise performance more as compared to the beta 1 selective agents. So beta 1 selective agents actually prevent the depression in the exercise performance. Now, beta 2 receptors, what is their role? So beta 2 receptor blockers, They actually lower down the lipolysis, and they also depress the glucose metabolism. Mechanism is simply the depression of the circulation in the skeletal muscles. Then you need to know about the role in, now this is I've written CHF, actually it should not be CHF, it should be actually coronary artery disease, that is CAD. That is by mistake I've written here CHF, so please just think about it as coronary artery disease. So what about the beta blocker role in the coronary artery disease? You need to understand that. Then in the state of stress and exercise, the coronary artery perfusion, that is circulation or the blood flow, that is enhanced. So the effect of catecholamines is also enhanced, increase in the heart rate, systolic pressure, oxygen demand is increased. But that is in the normal situation, that is in the exercise situation, in the normal state. But what happens when there is coronary artery disease, that is CAD? The perfusion is not up to the mark, so there is lack of perfusion, and in the case of exercise along with coronary artery disease, there it leads to ischemia. So now what is the role of beta blockers in this particular state? The oxygen consumption is not much affected if the beta blockers are used. And if the beta blockers are used, there's a healthy balance of the oxygen supply and the demand. Then this is all about the coronary artery disease. Now you need to know the effect of beta blockers in the hypertension, because they are very commonly employed as antihypertensive agents. So in subject of hypertension, they decrease the blood pressure. Mechanism is a little vague, but we can understand it, like we can decipher it out. You know that beta 1 effect is the release of renin. So beta blockers, they block the release of renin. And another vague mechanism that is exhibited by the researchers is that by the chronic or the long-term use of the beta blockers, it leads to decreased peripheral vascular resistance. You remember I just told you the effect on the peripheral vascular resistance. So long-term and short-term use, you can apply this fact here. Then along with that, cardiac output decreases. All in all, it equals to the antihypertensive effect of the beta blockers. And lastly, another fact I want to tell you, if there is added on like beta blockers with the alpha blockers, then vasodilatation is there, NO production is there, and they all actually lead to antihypertensive effect. Now, what about the role of beta blockers in the pheochromocytoma? They should be employed or they should be administered only after the proper alpha blockade. Because when the tumor secretes in pheochromocytoma, there is excess of adrenaline or the catecholamine secretion by the tumor. Then excess vasoconstriction occurs by the adrenergic receptors. It is actually hampered by this use of beta blocker. So if there is a proper use of beta blocker, that is administration after the alpha blockade, then better results they are achieved. So that was all about the summary, that is weekly podcast summary that I wanted to let you know, and I wanted to try on this live for this weekend classroom. I think it went okay. I think it did. I don't know. You please put down in the comments how did you like it, and what all like modifications or for the betterment, what all I can do. I think the slides, there was only one mistake. There was CAD not written in place of CHF. There should have been CAD in the last slide. And now I want to give just a little like direction for the detailed detailed podcast. You can visit www.ispharmacologydifficult.com. You'll also get a glimpse of my books there and other updates. And for more, like, you can also visit my page, drradhikavijay.com. So these are the two most important websites you can visit, and you'll get all the links via these websites. I hope you like this concept again of the introduction of the weekend classroom. Please let me know via the comments and what all improvement can be done. Especially I'm talking about the live part because I'm not very used to doing live. It was just a kind of a little experimentation, though everything was prepared, slides and all, but still there was a little experimentation. So do let me know your comments. If you like this video, it was of a little value to you, don't forget to hit the like button. Don't forget to subscribe to my channel. At the same time, stay tuned for more of the things. I'm sure you might have watched the video about channel updates and the planning and all. So I'm adding a little content along with this pharmacology podcast. That is why I've renamed the channel also. So all in all, I think that makes a lot of sense and it has made the content a little more interesting and engaging. What are your views about it? Do let me know. Till the next time, thank you. Take care. Bye bye.